Oh, can you guys see that slide okay?
Yep.
Okay. Awesome. Well, thank you for the invitation to speak today and to present some of my work. It's a tough act to follow after Jack's stuff there, which, as I said in the question period, was really interesting. And I think although it is a very different aspect from what I'm going to talk about, it does apply really well in a number of areas. And so just before I get into my talk, a little bit about myself. So I've studied in a bunch of different areas in a bunch of places across Canada. So in Saskatchewan, where I'm originally from, and then to the University of Calgary, where I did my PhD, University of British Columbia, and then here at McMaster, where I started as an assistant professor in 2019. And so the faculties that I've been in relating to sort of this interdisciplinary nature of my research is kinesiology, computer science, faculty of medicine, and then the faculty of science currently here at McMaster. And this is just kind of a little word cloud looking at the titles of some of my publications. And so it highlights the work, the focus of the work that we do in our program, which is primarily wearable sensors, looking at gait and osteoarthritis or aging populations. And so that's what I'm going to speak about in this talk here. I'll try to cover it in a bit of a broader overview and then have some good time to dive into questions at the end. So as everyone knows, wearable technology is a huge industry. They said it's about a $34 billion industry in 2020. And we generally think of smartwatches, and Jack talks a lot about different uses for smartwatches. And really what they're doing is they're using inertial measurement units to track the quantity of motion, and maybe they're doing some other things in there as well. But for the most part, what these sensors, the commercially available sensors, are doing is they're looking more so at the quantity of motion. So how much people are moving, how often people are moving. But the question is, can they do more than just track that quantity of motion? And the answer is that, as I'm sure everyone here knows, is that yes, they can. They can do a lot more. And really, we can get at specifically walking patterns or gait and human movement analyses outside of the lab. So the things that we would do in a conventional biomechanics lab, where I'm sort of trained, where we have optical motion capture cameras, we have force plates in the ground, we know that wearable sensors can actually do very similar things. So we can get at not just the quantity of gait, but actually the quality of gait. So now we're looking at diving deeper into gait with these sensors. And there's lots of different applications that we can use these for when we're getting into the quality of gait or the quality of movement. So running injuries, sport performance, but more specifically to things that we will discuss here is topics related to aging and osteoarthritis. And so just a brief outline of what I'm going to cover in this talk, really into three main areas. So what can they measure and how well can they actually measure it, which is an important question. We'll talk about some applications to osteoarthritis that we've seen, and then I'll finish up with an intersection with machine learning that I'll touch sort of briefly on some of the things that we're doing going forward. So when I was putting this talk together, I did a search just this week to see what the amount of studies that are in this area. So again, as I'm sure everybody knows, there's a lot of research in this area, but we can see this here. So this is the number of publications by year since 2000, doing in a database search in PubMed, looking at wearable sensors and all kind of the general terms that fit in that space, and movement, so looking at gait, exercise, things like that. So we can see that this area of research is on the rise. There's tons of studies coming out. There's over 17,000 hits that came up from 2000, and more so 2/3 of those studies have happened since 2015. So this is a really growing area, and there's lots and lots of research involved in all this. And so then the question is, what can they measure? And I mentioned at the start there that the smartwatches, a lot of times, they're really just looking at the quantity of movement. And so we can go from things like daily step counts, distance, velocity type things, as well, all the way to the far end of the spectrum where we're looking at joint angles, and we can really measure kind of everything in between. But for this talk, I'm focusing primarily on gait or movement analyses rather than sort of the physical activity side of it, but specific to gait. And so again, then the question is sort of what can they actually measure? So just to give kind of an overview of a number of these different metrics that we can measure with wearable sensors. So whether we have wearable sensors on the foot, the shank, the thigh, the back, or even on the upper body, we can get basic things like spatial temporal parameters. So we can divide the gait cycle into one stride that has stance and swing, right? And we can look at step time, stride time, step length, all of these more basic parameters that are describing the spatial and the temporal parameters of ambulation. And so if we look deeper at this signal, this is from a gyroscope on the dorsum of the foot, we can see this repeating pattern as people are taking multiple steps. And pulling those spatial temporal parameters from that is relatively straightforward. We see this consistent pattern, and we can pull up the timing of all these events. And what you'll see is that things look quite consistent and quite similar, but there is slight variations across this signal and across these spatial temporal parameters, which means that not only can we look at the mean values of these, but we can look at the variability of them as well. So how much variation do we have in these parameters as someone is walking? And what we found is that these measures of variability are a good measure of people's gait health or their general aspects of health. One of the early studies I did in this area is looking at just simply healthy young and healthy older adults. And what we see is that as people age, we have more variability in their gait. So there's a sort of this increase in variation from step to step. And this is even in healthy adults, this is going to happen. So functionally active, healthy adults. But we see it expand even more so when we look at this example here from another publication in 2007, where we're looking at an 84-year-old adult who's considered healthy. So we're looking at stride times here over 6 minutes. So we're just plotting individual stride times in this figure. And we can see that in this healthy adult, there's going to be some variation from step to step, obviously. But in this adult here who's identified as a faller, they've fallen multiple times in the year, we have a lot more variability happening in this person's gait. And we can even dive into these long range patterns, which I'm not going to dive into right now, but we can get at the fact that it's not just simply how much variation we have, but it's the structure of how that variability comes into play, that we start to lose this organization of gait as people age, and more importantly, as they move into sort of frailty or these clinical conditions. And so there's applications to aging, as I said, for looking at these spatial temporal parameters, the variability, or even some of these long range factors. There's applications to fall risk and neurological disorders based on that figure that I showed in the last slide, and then osteoarthritis and other things like running injuries. So looking at these seemingly basic parameters can provide a lot of information that can be really beneficial in understanding these changes that we see in movement. And then diving a little bit deeper, we can go into looking at the magnitude of acceleration. So what this really means is that if we attach a sensor to someone's shank or to someone's foot or thigh, we can actually look more specifically at the signal and see what the actual magnitude of those impacts are. So this means if you're walking or you're running, your foot is striking the ground, we can look at the magnitude of that impact, that acceleration impact. We can look at it as just an overall resultant acceleration, just the magnitude, or we can do it in 3 dimensions with triaxial accelerometers. And similar to those other ones, we know that there's some great applications to running injuries. So again, how hard someone's foot is hitting the ground is an important piece of information that we can gather quite easily from these sensors. We can look at it in relation to osteoarthritis. So we'll talk about osteoarthritis specifically here in a few slides, but getting at these musculoskeletal disorders, if we understand some more about the impacts, it can really help us to understand what's going on with these patients. And then at the furthest end of the spectrum here, or near the furthest end, is getting at 3D joint angles. So again, as I said at the start, trying to replicate what we do in a conventional lab with motion capture cameras. And so we know that whether it's using a full 4 sensor system on the lower limbs, or XSense, for instance, which uses 17 sensors, or even just 2 sensors, we can try to replicate joint angles. So the actual angle between the thigh and the shank, we can try to estimate that from these sensors. And this is a huge area of research in terms of gait analysis, which applies to a number of different areas: aging, fall risk, again, osteoarthritis, sport performance, and beyond. And then, so the next question is, how valid and reliable are these measures? We know we can measure a bunch of things, but how good are we actually getting those? And so this is a publication that we had a year or so ago, looking at the validity and reliability of these sensors. And what we found, just to kind of touch briefly on all these, relating back to some of those that we talked about, is that for the most part, if we're talking about mean spatial temporal parameters, these sensors are really good at doing that for the most part, whether it's at the back or in different positions. For the most part, they are quite good at measuring those spatial temporal parameters, which you might expect. When we're talking about variability, and again, variability, we're looking at sort of the not just the mean value, but the standard deviation here, or the variation that's occurring in those. We see a really wide range of accuracy and validity in these measures. But it's more so that we lack a consistent protocol. So people are doing things very differently across the board in how they're measuring these things. And that can cause some issues when we're looking at things like variability that maybe aren't present when we're just simply pulling out a mean parameter. And then getting to those joint angles. So for the most part, sagittal joint angles, we're really good at doing, or quite good at doing. Frontal plane angles, pretty good as well. But again, there's a lot of variety, and there's a lot of different ways that these are applied, not only in systems, but in algorithms. And so the big takeaway from this, this meta-analysis that we did is that there's really a lack of high quality studies and consistent research evidence. But the important thing to note here is that it's not necessarily a limitation in the device, as I would say. It's more the limitation in the protocols across these studies, so that we have varying levels of quality, different approaches, but it's not necessarily the device itself. And so I think we need to focus on improving on our consistency in these studies, the quality of them, and how we're reporting them. And then just relating this to some work that that will be touched on in the student section by Zijing, a student that I'm working with Ron. We're looking to estimate some of these knee joint angles, similar to what we talked about before, but looking at multiple sensors. So as I don't want to step on her talk too much, because she'll kind of go through this, but really we're looking at using multiple sensors to see if we can improve on these estimates, to see if there's better placements than others, and to try to develop these robust and agnostic models. Interestingly enough, as similar to Jack's presentation, looking at sort of agnostic acoustic models, we can try to do the same thing for movement as well. And then so coming back to this figure here, where we saw this huge increase in publications looking at wearable sensors and movement, what we don't have as much of is this overlay of older adults. So what we're seeing here is this same study now in orange. These are the studies, specifically the studies that are looking at research focused on older adults. So obviously there's a lot of other research going on relating to wearable sensors and movement, but there's again still this growing level of interest in publications and research and momentum that is around this wearable sensor space. And now even 3/4 of them have been published since 2015. So I think we're, as a program, in a great space because this area is continually growing. And one of the main areas that we see these sensors applied is something called osteoarthritis, which I've mentioned a few times throughout the talk already, but just to kind of step back and discuss osteoarthritis, if you're not fully clear or haven't seen osteoarthritis before, it's a disease of the synovial joints in the body. It relates to these structural changes in the cartilage and the bone. It leads to changes in pain, reduction in function, and an overall reduction in the quality of life. There's no cure for osteoarthritis, and we expect that by 2040, almost a quarter of Canadians will be affected by that, and it's a huge burden on our economy. And as I'm sure many people know, with COVID right now, it's not only affecting our minds, but it's affecting our bodies. We're not able to move as much. And I would expect that based on, the lack of movement that people have, we have an aging population, this number may actually be greatly affected by, indirectly by some of the things we have with COVID and going forward. And so, as I said, the conventional movement analysis that we do in a gait lab, where we have cameras, we have force plates, we can do all this great stuff, it has been really useful and really important in understanding osteoarthritis. But to try to translate this to impact people in their sort of daily lives, we really need innovative technologies. We need new methodologies to try to get and drive that change. And so, again, just presenting another kind of review here, just to give a nice overview of things. We did a scoping review this year, looking at where sensors are being used in assessing gait in osteoarthritis. Because again, as I said, it's a bit of the Wild West out there, where we have all of these different sensors, we have all these different applications, and we have many different ways that it's being analyzed. So trying to kind of bring this together to see where we're at and what's being done out there. And so what we found is that there was 72 studies that were included in this. In terms of the designs, as you might expect, most of them were looking at cross-sectional research. So the figure here is looking at the publications by the year, similar to some of those figures that I presented previously, just the more general ones. But this is specific to inertial sensors, to looking at gait and osteoarthritis. And so the blue color here relates to cross-sectional studies, primarily looking at comparing the gait of people with osteoarthritis to healthy controls, which is really important information to have, but it's not the most impactful information. These sort of orange areas here relate to the effect of surgery. So using these sensors to actually compare either before and after, or the effect of surgery. So there's a growing area of research in looking at the effect of a total knee arthroplasty on someone's gait, and using sensors to help clinicians do a better job with that, which is really, really promising, I think. In terms of placement, so this figure looks at the number of the different types of metrics that we saw in the literature out there. And what we saw is that the back or the pelvis is by far the most common placement for sensors to look at gait in people with osteoarthritis, followed by the shank. And if we look at the specific metrics, again, tying it back to some of those metrics that I talked about previously, the most common is looking at mean spatial temporal parameters. So step time, stride length, things like that is by far the most common. And then looking at segment angles, so looking at the actual angle of either the shank or the thigh, or even tying that into a joint angle at the knee. And then thirdly, the actual magnitude itself. So again, that's that impact of the foot hitting the ground. And so what we can kind of take away from that is that for future research, there's definitely a need for more longitudinal study designs, which is a relatively common finding when we're reviewing literature. It's always great to have more longitudinal study designs. And although we do have a growing number of surgical studies, the one area that's really lacking, that there's no studies in, is looking at wearable sensors in relation to progression. So being able to track progression, to see how people are changing over time, there's really no studies that are looking at that. And it's a great use for wearable sensors. There is growing use for patient-specific applications. So again, using these to develop changes within a patient or specific, within subject models. And then there's a need for free living assessments in gait in patients with osteoarthritis. So those 72 studies, none of them had any actual free living data. And what I mean by free living data is that essentially allowing the user to have a sensor on and collect measurements of gait in their daily life. Most of the times, although we're moving out of the lab, we're still doing it in a very controlled clinical setting. And there's really no direct assessments of that free living gait in people with osteoarthritis. And so I think kind of the big take home from that is that these wearable sensors offer us the ability to collect and amass huge amounts of data very quickly on an individual. And I think we need to do a better job of taking advantage of that. And that's where kind of this machine learning side comes into play. And so just to kind of wrap up, I'm not going to dive too much into the machine learning, but I do want to touch on some of the things that we're working on, or we'll be working on, because I think that the integration of this wearable technology with machine learning is really what gives us the ability to solve or to improve on some of these MSK problems, these disorders going forward. And so the first thing is to try to make outcomes more interpretable, more meaningful, and more actionable. So I presented this slide at the start here, where we have essentially the more basic spatial temporal stuff on the left, the more complicated joint angle stuff on the right. And while it can be great to present some of this information, trying to think up different ways to present that information that can be meaningful or actionable for either the user or the clinician. So one of the ways that we've done this in the past is looking at an exercise program and tracking someone's gait before the exercise program and trying to identify if they are a good fit for that program based on what we know about who responds well to this exercise intervention. And so rather than simply presenting them with some joint angle curves or some numbers, we're actually giving them, the clinician specifically, a more actionable set of information to say, based on how this person's walking, using these sensors, we expect that they're a great candidate for this program. So again, there's many different ways that we can do that. This is just one example. And then, as I said, advancing these to measuring free living conditions. So there's a lot of research in going from raw movement data, so taking just free living data of a sensor in the real world and classifying activities. And there's also a lot of research looking at getting events and segmenting out walking strides from running, from stairs, and all these other events. But there's really a need to develop sort of a top to bottom system that can allow us to simply throw a sensor on someone for 1 day, for 7 days, for more, and have all this data segmented out so that we can do some really interesting analyses on it. And so we're developing these pipelines to do just that. And then Zarian, he's going to talk a little bit about this area, but trying to understand the normal day-to-day fluctuations in relation to clinical changes, because we know that gait varies from day to day. And this is especially important when someone has a clinical condition like osteoarthritis, and understanding these normal day-to-day variations in respect to more important clinical changes is really important. And then lastly, trying to integrate this movement data with other sources of data in more patient-specific models. So I think it's really important to remember, and I think that's something that I believe we've been quite good at in this program, is trying to remember that there's a lot of different aspects of health, and the user design has been a big piece, the co-design piece of trying to remember. I spoke a lot about the mechanical side, about gait and movement, but at the end of the day, this is just one aspect of this patient who has knee osteoarthritis, and there's a number of different factors here. And so really, we're not trying to just answer everything with the mechanical side, but we're trying to help clinicians to have some information into that piece and to build out the full patient specific model with that. So that being said, I'll wrap up here. Again, thank you for the invitation, and look forward to anyone's questions.
Okay, thank you, Dylan. Thank you for the inspiring presentation. And I strongly agree with the protocol part that you mentioned, because when I'm looking at the IMU application in the gait analysis, a lot of studies have like kind of low comparison ability with each others. And yeah, thank you for the presentation. And let's see if we got any questions.
Yeah, I think as we kind of wait here for somebody to jump in, I think that's a really good point, and that was one of the difficulties in those analyses, the meta-analyses and the reviews, is trying to compile the data together, because there's so many different, not only applications, but different types of walks. So the variability stuff we looked at, the image that I showed was 6 minutes of walking, but sometimes people will pull out a variability measure in 6 steps of walking and everywhere in between. So it's quite variable.
Yeah, that's true.
Intended.
Just to follow up that question, like we've been talking about mobility is the sixth vital sign. I even use it in the proposal, but we don't really have mobility measures or even gait parameters as something like we put in our medical record, like we would have done with our blood tests or blood pressure and things like that. I'm just curious, like even in a clinical setting, do people actually keep track of those, like gait parameters, and when people come to the clinic, like use it as part of the medical record? What is the current practice right now?
Yeah, that's a really good question. So I would say unless you're going to a specific clinic that's measuring that, then obviously that's not being tracked. So for instance, in Calgary, we had a physiotherapy clinic that would measure all this, and we'd give reports to people, and all this information would be tracked internally, but by no means is it medical data that goes into medical records. And same thing can be said at sort of an osteoarthritis clinic that is measuring these things. They are potentially using it to help inform surgery, but again, by no means is it sort of that medical data. And interestingly enough, we actually had a chat just a couple of weeks ago about this. And your analogy is perfect for blood pressure, right? That was exactly what we talked about. Is a gait, we need a blood pressure measure. We don't have that. The closest thing that we could say is maybe gait speed is a really, really great sort of measure to track. It's very broad, but it's kind of predictive of a lot of things. When it comes to osteoarthritis, though, we might say something like the knee adduction moment, which is a really specific thing that relates to sort of the loading of the knee, that maybe that is a better sort of blood pressure type metric that we can track going forward. But the difficult thing with that is that we just don't have the ability to do that in a consistent basis across these different areas. So I think that's somewhere we should be looking to move to collecting some of that stuff and having it with, again, that whole patient profile. But we just don't have that right now. Wearables offer a really good opportunity to potentially do that because of the accessibility of it, but it's really not there yet.
Yeah, I think if it hasn't been done, maybe something we can propose to CSLA to keep track of those information. Thanks.
Yeah. Exactly.
May I add a few more comments to Ron's? Actually, that is important, although one might argue, I've heard this before, that the data collected is too much, but come to compare it with MR records, it is really not that big. So I think there should be a way to put those things in the electronic or medical records so that patients can be tracked, because especially although not common practice that people, especially after an old age, move around much within a region, but still in a particular region that individuals progress or decay should be tracked so that proper actions can be taken over in the future, right?
Yeah, I think that's a good point, and especially as you said, in relation to MR and imaging, we track that pretty well. If somebody has X-rays for osteoarthritis or an MRI, that's in their health records. But we know that a lot of times an X-ray isn't always as clinically meaningful as something as simple as gait speed in terms of their function and their pain levels. So I do completely agree with that there's no reason that we can't be doing that. And as you said, Ron, with the CLSA is a great example. I know they have a number of functional measures that get at some of these basic things, and those are collected in different clinical settings, like timed up and goes, and different like chair rise tests. Those are collected, and a great kind of start to have a base measure of that. But I think there's a lot more that we can do.